আজকের আমরা কথা বলবো লিভার ডিজিজ ইন প্রেগনেন্সি। There are 4 headline under liver disease in pregnancy. The most important is acute fatty liver of pregnancy. Acute fatty liver of pregnancy. In short, acute fatty liver of pregnancy, AFLP. And the second most important is HELLP syndrome, HELLP syndrome. And number 3, obstetric cholestasis. Obstetric cholestasis. And number 4, viral hepatitis. Viral hepatitis. In short, we will talk on these 4 points. At first, the acute fatty liver of pregnancy. Acute fatty liver of pregnancy. It usually occurs in 3rd trimester of pregnancy. Patient usually present severe vomiting, abdominal pain, and jaundice. So be careful. A third trimester ongoing pregnant lady present to you with vomiting, abdominal pain, and jaundice. With this scenario, you can assume that this could be a case of acute fatty liver of pregnancy, or this could be a case of HELLP syndrome, or this could be case of viral hepatitis, mostly hepatitis E virus. So with these 3 differential diagnoses, you should clarify other symptom. Patient may have polydipsia. That means excessive drinking of fluid, water intake, and polyuria. On investigation, liver function test will be abnormal. That means SGPT or SGOT, that is ALT and AST, both will be raised. Serum bilirubin will be raised. Proton mean time, that is INR, will be prolonged. Serum albumin may be normal or maybe somewhat a little bit low. So with this investigation, along with ultrasonography of whole abdomen, will show a bright liver. Bright liver means fatty liver. It may be a grade 2 or grade 3, and liver may be enlarged in size or maybe normal. So these are the panel of investigation that can be helpful for the diagnosis of acute fatty liver pregnancy. Liver biopsy usually not needed, but if liver biopsy done, then it will show the microvascular stenosis. That means the lipid particle deposition inside the microvessels. Okay, so what will be the management, or what will be the treatment? Supportive treatment at first, and definitive treatment is delivery of the baby, delivery of the fetus. Okay, as because uh, there is a high chance of fetal morbidity or mortality. Actually, uh, the question is, what is the complication of acute fatty liver pregnancy? Okay, so what is the complication of acute fatty liver pregnancy? Number one, fetal death, fetal death, and number two, there is inherited deficiency of LCHAD, LCHAD. That means long chain acetyl dehydrogenase. This is an enzyme. This is an enzyme. So these are the two complications which are usually found in uh, uh, acute fatty liver of pregnancy. Now, the second most important is HELLP syndrome. We know HELLP, that is hemolysis, hemolysis, elevated liver enzyme, elevated liver enzyme, then low platelet count. So these are the 3 points in HELLP syndrome. Uh, we we must remember, keep in our mind that HELLP syndrome actually occur. HELLP syndrome actually occurs on the background of preeclampsia, okay, or eclampsia. So HELLP syndrome, when we suspect a patient that it could be a case of HELLP syndrome, and before going this diagnosis, we ensure that the patient has the evidence of preeclampsia or eclampsia. That means patient will be hypertensive, okay, will be hypertensive, maybe leg edema, okay, uh, visual disturbance, okay, visual disturbance, headache, okay, proteinuria maybe, or high color urine, and so on. We know what are the features of preeclampsia and eclampsia, and may have convulsion and so on. So patient develop HELLP syndrome on the background of preeclampsia and eclampsia. So in this patient, the investigation finding will be uh, features of hemolysis. That means hemoglobin percentage will be low and reticulocyte count will be high. That is more than 2%. And hepatic enzyme, liver function test, ALT will be increased, and AST of course will be somewhat increased. Also PT will be increased, INR will be increased, and bilirubin will be increased. So very simple investigation here, and most importantly, the platelet count on CBC, ESR will be high, and platelet count will be low. The patient may have coagulopathy. So PT, INR, APTT, all these may be abnormal. So how will you manage this patient? How will you manage this patient? That is the HELLP syndrome. Number one, the supportive management. Number two, delivery of the baby, delivery of fetus, and before that, if possible, correction of or management of hypertension. that is blood pressure, and you may need to infuse a magnesium sulfate, that is Maxol IV, and you may need parenteral, that is IV antihypertensive. So these are the point of management of HELLP syndrome in short. And number 3, obstetrical cholestasis. Cholestasis, stasis of cholesterol, sorry, stasis of bile during pregnancy. In normal pregnancy, mind it, in normal pregnancy, alkaline phosphatase ALP is mildly raised. This is the normal finding. Okay, mind it. This is the normal finding that in normal pregnancy, alkaline phosphatase is mildly increased. So, in a patient with genuine obstetric cholestasis, by seeing raised alkaline phosphatase, you may not be sure that this is a case of obstetric cholestasis, as because in normal pregnancy, alkaline phosphatase is mildly raised, and obstetric cholestasis also alkaline phosphatase is not so raised, maybe mild to moderate raised. So it might be confusing for you, for us, to make a diagnosis of obstetric cholestasis. So what can we do to reach the diagnosis of obstetric cholestasis? We can go for serum bile acid estimation. Okay, serum bile acid or bile salt. So serum bile acid will be raised due to intrahepatic cholestasis in pregnancy. And actually, this obstetric cholestasis patient present present with pruritus, that is itching, whole body, most importantly palm and sole. And we know the pruritus or cholestasis in obstetrical jaundice or obstetrical cholestasis is due to actually the accumulation of high level of bile acid. So how will you manage? Management is very short, very simple. 800 deoxycholic acid. 800 deoxycholic acid. Mind this. Keep this name on your mind. Usually 250 milligram BD is enough, and usually by 7 to 10 days the patients get relief of pruritus, and sometimes for soothing effect, a menthol water-based cream can be used on the palm and sole to relieve pruritus or itching. Here, of course, also the delivery of the baby may be done earlier. Okay. Now, the number 4, that is viral hepatitis. We are talking about the liver disease in pregnancy, and is the number 4 point, that is the viral hepatitis. During pregnancy, 4 virus are important: hepatic virus, hepatitis B virus, hepatitis C virus, and hepatitis E virus. Okay. At first, hepatitis B virus, mind it, the hepatitis B virus is very notorious, and there is 90% chance of vertical transmission from mother to child. So the baby of the mother with hepatitis B virus infection must be vaccinated and immunized with hepatitis B vaccine and hepatitis B immunoglobulin. I repeat again, the baby of hepatitis B virus infected mother should be vaccinated by hepatitis B virus vaccine and hepatitis B virus immunoglobulin also given just after birth. And it should be given as early as possible after birth, uh, of course, within 48 to 72 hours. Okay, this is all about hepatitis B virus infection in pregnancy. Now, hepatitis C virus. Vertical transmission of hepatitis C virus is very low, but if the mother is co-infected with hepatitis, the HIV virus, human immunodeficiency virus, then the vertical transmission, chance of vertical transmission is very high. I repeat again, the isolated hepatitis C virus infection, in case of isolated hepatitis C virus infection, vertical transmission chance is very low. But when the mother is co-infected hepatitis C virus and human HIV, then the vertical transmission chance of hepatitis C virus is very high. And in that case, only in the case of co-infection with HIV, antiviral should be given during pregnancy to the mother. In case of hepatitis B virus, I repeat again, in case of hepatitis B virus during pregnancy, antiviral to the mother should not be given, but it should be given just after delivery. And in case of isolated hepatitis C virus infection, antiviral to the mother not recommended, but if the mother is co-infected with HIV, then antiviral is recommended. Another virus is hepatitis E virus. Normally, hepatitis E virus is a self-limiting, benign condition, but the pregnant lady are more susceptible to acquire or to be infected by hepatitis E virus, and they are prone to develop fulminant hepatic failure. Very important information it is. In normally non-pregnant lady or general population, hepatitis E virus is a self-limiting benign condition, but it may be fulminant, may be life-taking, and may lead to fulminant hepatic failure in pregnant lady. And it is a waterborne infection that is spread by fecal-oral route. So pregnant lady, pregnant mother should be careful regarding their sanitation and drinking water. So how will you manage this case? Management is non-specific, that is general management, supportive management. So this is all about the liver disease in pregnancy. So thank you very much.